Capillaries are the smallest blood vessels and they form a network that connects arterioles with the venules and nourish the tissues. Capillaries are the site where actual exchange of nutrients and gases take place, and its average diameter is 4 to 10 micrometers. Capillary lumen at places may be narrower than the diameter of RBCs. Like RBC diameter is 7.2 micrometer. So RBCs need to get folded upon themselves to pass through the capillaries, and these capillaries are mainly formed by endothelium resting on the basement membrane. So histologically, capillary consists of vascular endothelium and its basal lamella, and there is no tunica media or tunica adventitia in the capillaries. And as we can see in this figure, some capillaries also show presence of pericytes, and these pericytes are phagocytic in function. The pericytes are embedded in between the basal lamella and endothelial cells, and they are long oval, they have long elongated euchromatic nucleus, and there are several cytoplasmic processes that clasp the capillaries, and then the pericytes may get differentiated into smooth muscle cells or fibroblasts. Now, depending on the morphology, the capillaries are classified into three varieties: continuous capillaries, fenestrated capillaries, and sinusoids or discontinuous capillaries. So, first variety is continuous capillaries. In these, the endothelial cells are fused by tight junction. There is no space between the endothelial cells. Also, the basement membrane is complete, or it is continuous. It completely surrounds the endothelial cells. In continuous capillary, exchange of nutrients take place through the cytoplasm of endothelial cells, and there are the way is known as transcytosis, in which the endothelial cells show pinocytic vesicles in the cytoplasm, and there is tight junction, so it restricts the passage of large molecules. And continuous capillaries are located in the connective tissue, in muscles, skin, lungs, and central nervous system. Second variety of capillary is fenestrated capillary. So in fenestrated capillary, the endothelial cells are not connected by tight junction, but there are spaces in between the endothelial cells in the form of circular openings known as fenestrations or apertures, or we can say pores, and these pores are about 50 to 80 nanometer, but the basal lamella is continuous and it covers entire capillary. Means spaces are present in between the endothelial cell, but the basal lamella is continuous. And there are a few concepts regarding the fenestration. According to few authors, the fenestrations are developed because the upper part of the endothelial cells are pinched off during the process of pinocytosis, and the endothelial cells lose their apical portion on pinocytosis, leaving behind these fenestrations or gap. And according to some other authors, the fenestrations are closed by a non-membranous diaphragm that consists of thin layer of cytoplasm and basal lamella, and these diaphragm closes the filtration pore or the fenestrations. And such fenestrated capillaries are located in renal glomeruli. They are seen in pancreas and other endocrinal glands, then in intestinal villi, choroid plexus, in the ciliary process of the eye, and gallbladder. Third type of capillaries, sinusoids or discontinuous capillaries. Histologically, these are large irregular gaps. Means the wall of the blood vessel is not continuous. There are large irregular gaps in the wall of the blood vessel, because the endothelial cells are also not connected, means there is gap in the endothelial cells and also in the basement membrane. And the gap or the large pores or slits are present in between the endothelial cells, and the basal lamella is also not continuous. And as the blood flow is sluggish, exchange of any molecule is easy. And the this discontinuous capillaries are located in liver, spleen, lymph node. They are present in the bone marrow and in the carotid bodies. In liver, sinusoidal walls show two special types of cells. Kupffer cells are phagocytic and Ito cells are storing vitamin A. In spleen, the endothelial cells have unique elongated shape, and they have gaps between the adjacent cells. Cavernous tissues are blood-filled spaces lined by endothelium and surrounded by trabecules containing smooth muscle fibers. Arterioles and the venules directly open in these cavernous spaces, and the cavernous tissue is present in erectile tissue of penis and clitoris. It is also found in the nasal mucous membrane. When communication is established at the level of precapillary or postcapillary neighboring vessels, it is known as anastomosis. Anastomosis is of three types: arterial, venous, and arteriovenous. Arterial, again, interarterial means between the adjacent arteries, either by their trunks, branches, or sub branches, and it can be actual or potential. Actual means the blood spurts in both direction from the cut end of anastomotic vessels, and the anastomosis is actual. Example is between right and left gastric arteries. And potential anastomosis means if the blood flows in one direction only from the cut end of the vessels, and potential anastomosis is seen between the right and left coronary arteries. When the arterioles communicate with venules bypassing the capillary network, it is known as arteriovenous shunt, and it diverts the blood from capillaries. And arteriovenous shunts are normally located in the skin of fingertips, in at the tip of the nose, lips, erectile tissue of penis and clitoris. The structure of arteriovenous shunt is, it may be straight or coiled, and the walls of these shunts are lined by endothelium. There are several layers of smooth muscles, and contraction of smooth muscle closes the AV shunt, and it enhances blood supply to the capillary plexus. Means when the shunt is closed, the blood will flow through capillary plexus, and when the shunt is open, the blood will bypass the capillary plexus. And its function is thermoregulation, then erectile function. And AV shunts are poorly developed in newborns and old persons. Then a specialized variety of arteriovenous shunt is glomus. It is formed by a round bunch of vessels found in skin at the tip of the fingers and toes, lips, then the tip of tongue and nose, and the smooth muscle cells lining connecting vessels in the glomus are known as epithelioid cells because they appear epithelial in function, and their function is also thermoregulation. The arteries which do not anastomose with their neighboring vessels, or when the branches of the arteries also do not anastomose with their neighboring vessel, they are known as end arteries. End arteries do not form any precapillary anastomosis, and the example of end arteries is central artery of retina, then splenic arteries, cerebral arteries, renal arteries, arteries in the lungs, vasa recta of small intestine. And the clinical significance of this artery is that a single artery is there which do not form any anastomosis, and it supplies a certain organ. And if this artery is blocked, then the blood supply to that organ will be hampered, and the ischemic changes will occur in that organ, as no other blood vessel or there is no other collateral channel supplying that organ. And the example is central artery of retina, then labyrinthine artery. These are all end arteries. The veins are known as reservoir vessels, and there are four types of venous systems encountered in human body. There is caval system, portal system, azygous system, and paravertebral system. So the caval system drains blood into the right atrium from upper and lower part of the body through superior and inferior vena cava. Then in the caval system, we have some specialized veins like emissary veins are there. These are wall-less veins which communicate intracranial venous sinuses with extracranial venous sinuses. Then the intracranial dural venous sinuses are devoid of muscular coat and walls. Then the coronary sinus, it brings about 60% of venous blood of a heart to right atrium. And in occlusion of coronary artery, the coronary sinus may provide nutrition to the heart muscles through the arteriovenous anastomosis. And the bronchial veins drain venous blood from lungs by superficial and deep sets of the vein. Then the second system is portal system. Blood vessels which connect two sets of capillaries at their two ends are known as portal veins, and these are found in liver, kidney, hypophysis cerebri, and suprarenal gland. Then the third system is azygous system. It is straight in course, and these are paravertebral in position, and they are provided with walls which communicate caval system in front and vertebral venous plexus behind. Then the fourth system is paravertebral venous plexus of Battson's. It is having a great clinical significance in metastasis of carcinomas. So these are wall-less veins lying in within the vertebral canal in epidural space, and they communicate with azygous system, portal system, as well as caval system of veins. And the venous blood from prostate, thyroid, mammary gland, from these three organs, they will drain in the plexus in addition to the caval system. And in increased intracranial or in intrathoracic pressure, the venous blood from these organs bypass the systemic vein and they drain into the vertebral plexus, and this explains the vertebral deposition of metastasis from carcinoma prostate. Factors which regulate venous return are: first is pumping of the left ventricle. Then blood is also permitted by arterioles into the capillary bed, and massaging action of the skeletal muscle, and negative intrathoracic intra-abdominal pressure, suction of the diaphragm. Venous walls are present, especially in the lower limb. Then transmitted pulsations of the arteries. On either side we have the vena commitants, and except for the lower limb, rest of the body, gravity also helps in venous return. Veins are the blood vessels which carry blood towards the heart, and based on the diameter, veins are classified as venules. So the smallest veins are venules. Then comes the small veins, then medium sized veins, and large veins. So the smallest veins are called venules. Their diameter is about 0.1 millimeter or less. And venules are again of two types. Post capillary venules, their diameter is 10 to 50 micrometer, and they receive blood from the capillaries. Their diameter is less than 0.2 millimeter. They have endothelial lining resting on the basement membrane with few pericytes, and it is sensitive to inflammatory agents and it facilitates extravasation. Then the second type of venule is muscular venule. Its diameter is 50 to 100 micrometer. So these are slightly larger and they are lined by endothelium. 1 to 2 layers of smooth muscles are there and they are surrounded by a thick layer of connective tissue. When the diameter of veins is between 1 to 10 millimeter, they are known as medium-sized vein. Here the three layers, that is tunica intima, tunica media and tunica adventitia, are not well defined. We cannot differentiate these three layers. So first, again, here there is tunica intima. It has vascular endothelium resting on the basement membrane, and there is a thin subendothelial connective tissue, but the internal elastic lamellae is discontinuous. Tunica media is thin, it has few smooth muscle cells, and adventitia is thick, it has connective tissue containing collagen and elastic fibers. Then the medium-sized veins accompany the arteries, like a radial vein accompanies radial artery, tibial vein accompanies the tibial artery. So mostly they accompany the arteries, and medium-sized veins show presence of walls in them, and these walls prevent regurgitation of blood or backward flow of the blood through the venous walls, and these are most prominent in lower limb as they have to means the venous return in the lower limb is against gravity. So these walls are very important and prominent in the lower limbs. And example of medium sized veins are femoral vein, then superior mesenteric vein, tibial vein, popliteal vein. When the veins have diameter more than 10 millimeters, they are known as large veins. And the large veins have all the three layers in them: tunica intima, tunica media, and tunica adventitia. Tunica intima consists of vascular endothelium resting on the basal lamella, and they have a thin subendothelial connective tissue which contains few smooth muscle cells in it. Then the tunica media has concentrically arranged smooth muscle cells, collagen fibers, and fibroblasts, and it is difficult to differentiate tunica media from tunica intima. Then the tunica adventitia is the thickest layer in large veins, and the significance here is that the smooth muscles are arranged longitudinally, and also tunica adventitia has more amount of collagen fibers, elastic fibers and fibroblast. We can also see vasa vasorum and nervi vasorum in the tunica adventitia. And the example of large veins are superior vena cava and inferior vena cava. Let us see some interesting facts regarding veins. Generally, we have veins in two sets: superficial veins and deep veins. Superficial veins lie deep to the superficial fascia and they run independently, whereas deep veins run under the deep fascia and mostly they accompany the arteries. Then the vena committens means we have a centrally placed artery and a pair of veins on either side of the artery. Vena committens helps in return of blood towards the heart by transmitted pulsations of the arteries. Vena committens also helps in countercurrent heat exchange between arteries and veins. Then the veins, particularly of the lower limb, show valves in them. Valve is formed by reduplication of tunica intima. They permit blood flow in only one direction, that is towards the heart. Above the walls, the venous wall is dilated to form a sinus, and during raised intrathoracic or intra-abdominal pressure, walls nearest to the heart prevent venous backflow from extending into the limbs, head and neck. Then in case of large veins like superior and inferior vena cava, instead of circular layer of muscles, there is longitudinal layer of muscles, and this will facilitate elongation and shortening of vena cava with respiration. In lower limb, the muscles are well developed in the walls of blood vessel. The inner longitudinal and outer circular muscles are present, and this will help the lower limb veins to pump blood towards the heart against gravity and to overcome hydrostatic pressure of the blood. Then muscular tissue is totally absent in the walls of blood vessels, in the dural venous sinuses, pile veins, placental veins, retinal veins, veins of spongy bone, and corpora cavernosa and spongiosa of the penis. Let us know the clinical importance of veins. So first condition is deep venous thrombosis. In chronically ill patients who are with prolonged bed rest, who are bedridden due to post-operative conditions or due to some orthopedic conditions, when they are at rest or when they are immobile, then a thrombus will form in their medium-sized veins, especially in the lower limbs. And the danger of such condition is that the clot may get separated from the blood vessel, it may get dislodged, and this is known as embolism. And this emboli, if it enters the pulmonary circulation and if it blocks the pulmonary vessels, it is known as pulmonary embolism. So it is a fatal condition and may lead to sudden death. Then second condition is varicose vein. So this is permanently dilated, tortuous, superficial veins, mostly of the lower limbs, and it is seen in older patient, and the causes of varicose veins are incompetence of the walls of veins, then decreased vascular smooth muscle tone, or in some condition or some professions we need prolonged standing. So here again there is varicosity of the veins. Then esophageal varices are varicose varices are also seen in esophagus, anal canal, around umbilicus. When the portal hypertension occurs, then we can see such varicosities. So if esophageal varices are there, if the dilated veins are seen in the esophagus, if they get ruptured, they lead to hematemesis. Then in the anal canal, if these dilated veins rupture, means this dilatation is known as hemorrhoids, and if they rupture they can again cause bleeding. And the varicose around umbilicus is known as caput medusae, so it forms spoke wheel like appearance due to dilatation of superficial veins. So let us revise the difference between artery and vein. Histological difference. The walls of arteries are thicker and the wall of vein is thinner. The lumen of artery is open, it is patent, it is circular, whereas in veins the lumen is collapsed and irregular. Then the internal elastic lamella is visible in medium sized, that is muscular arteries, and in small arteries it is not distinctly visible in large or elastic arteries, and it is absent or not well defined in veins. The tunica media of arteries is the thickest layer. In veins, tunica adventitia is the thickest layer. So in case of arteries, the tunica media is formed by smooth muscles and elastic fibers. So in elastic arteries, more amount of elastic fibers are there. In muscular artery, more amount of smooth muscle cells are seen in tunica media. Whereas in vein, the tunica media is thinner and it consists of smooth muscle, elastic and elastic fibers, collagen fibers and fibroblast. Then the tunica adventitia is thinnest and strongest layer of arteries, and it has connective tissue and collagen fibers. In veins, especially in the large veins, the tunica adventitia has longitudinally arranged smooth muscles and few elastic fibers, and more amount of collagen fiber is there. And tunica adventitia is the thickest layer in case of veins. Then the layers, all the three layers are well defined in arteries, that is tunica intima, tunica media and tunica adventitia can be well demarcated in case of arteries, whereas in veins all the three layers cannot be differentiated, they are not clearly identified. Blood supply of large blood vessels like aorta, inferior and superior vena cava is by vasa vasorum. So in this slide you can see this is the tunica adventitia, in which small blood vessels are there, and these small blood vessels will supply blood to the walls of large vessels, and vasa vasorum mainly supplies entire tunica adventitia and the outer part of diffusion of blood present in the lumen supplies tunica intima and inner half of the tunica media. So this is the blood supply of a large vessel. So the blood supply is mainly by vasa vasorum, which supplies tunica adventitia and outer half of the media, and blood supply by diffusion of the blood present in the lumen supplies mainly tunica intima and half of the tunica media. Then coming to the nerve innervation, it is by autonomic supply. Afferents act as baroreceptor and chemoreceptor, and efferents mostly cause vasoconstriction and some are vasodilators. Again, we have to remember that sympathetic innervation causes vasoconstriction. We can consider heart as a large blood vessel, and similar to the blood vessels, heart also is made up of three layers. So the innermost layer is known as endocardium. It is lined by endothelial cells resting on basement membrane, and it is supported by subendothelial connective tissue. Then the second layer is myocardium. It is the thickest layer formed by myocytes, and pericardium is the outer layer. It is formed by visceral layer of serous pericardium.